Well, technology has a terrific role in any vascular access, and the technologies which are more important now and which will be more and more important in the future are the technology based on the safety of the patient and low invasivity and low cost, which basically is, for instance, in the insertion, ultrasound in all its aspects, the electrocardiographic method, the intracavitary electrographic method for tip location, and also the near-infrared technology for visualization of superficial veins. I think that these three technologies are very good examples of what will happen, what is already happening in the world of the insertion. And then there are other aspects such as technology in the maintenance. And also here there are terrific new devices which can help us, such as, for instance, the subcutaneously anchored system for the stabilization, or the transparent membranes, which are becoming more and more interesting and more safe for the patient. Well, in terms of the personnel who is in charge, who's empowered with vascular access, I think that the future belongs to the nurses. I mean, sooner or later, the nurses will take the field completely, of vascular access completely. It also already happens in some hospitals like mine, where all vascular access are potentially inserted by specifically trained nurses. And as a matter of fact, if you think about it, the role of the nurse, the professional profile of the nurse is exactly concerned with the how to convey the therapy to the patient, which is the basic of the venous access. On the other hand, I think that will be more and more focus on the cost effectiveness. Cost effectiveness means to reduce the use of fluoroscopy, to reduce the use of radiology, to perform all of the procedures not in the operating room, not in the radiological suite, but in a specialized room or even at bedside, and decrease the cost, but maintaining a high level of safety for the patient. Well, I think that Spain, as Great Britain, as France, as Italy, and also Australia might be at this moment one of the places where the culture of the vascular access is higher, deeper and more precise. If compared, for instance, to the United States, in which there are several things which are not optimal. First of all, in Europe, the real engine for the progression, for the revolution in the field of vascular access is the clinician. On the contrary, in the USA, very often is the industry, which is not so natural, in my opinion. Also, there is a fact that in Europe and in Australia too, we are not afraid of using devices off-label and inventing new methodology. On the contrary, in the USA, they have a sort of taboo of the off-label, and they are incredibly shy of introducing new methodology or to apply new methodology to evolved methodologies to new fields, because they are always afraid of doing something which might not be off-label. And this is something which really is a sort of a brake that stops the revolution. So I think that if you consider the major indicator of the healthiness, so to speak, of the culture of vascular access, they are all very good in Spain. For instance, the nations which are very high focused on nurses, where the nurses are empowered to insert the vascular access, obviously the nation with a high level of a culture in this field. And also the use of the new non-invasive technology such as ultrasound and intracavitary electrocardiography, which are becoming more and more popular in Spain like in Italy, is also a sign, an indicator of a better and deeper and safer culture of vascular access. Also, the association of vascular access. Italy has 2 or 3 associations dealing with vascular access, and Spain has 2. There are the nations where the culture of vascular access is very, very low, like Germany or Japan, for instance, where there is nothing, there is not one association. So I think we are very healthy. Both the Italian and the Spanish are quite healthy in the field of culture vascular access. I think that not by chance many important documents of the last few years came outside of the United States from Italy, from Spain, for instance, the very last very, very good guidelines for the treatment of infection, of catheter infection, and from Australia too, of course. Well, I tell you that also in Italy, in the last 2 years, there was a great uprising of interest in the field of neonatal and pediatric vascular access. In particular, the Gaveselt, which is my association, has created a sort of spin-off society, which is Gaveped, which is the group dealing with venous access device in pediatric neonatology. And not by chance, because this is the field where the revolution has been deeper in the last years. In the neonates, we have new materials, we have new kind of devices, we have new technologies. In neonatology, we have a wider and more focused utilization of ultrasound for all aspects of vascular access. Some of the technology which we mentioned before, such as the near-infrared technology, are particularly important in neonates and children. And also in children, the role of nurse-driven insertion and the role of peripheral inserted catheter is becoming stronger and stronger. So I think that there are a lot of things that we used to do 20 years ago in neonates and children, such as the venous gut down, the surgical preparation of the vein, or the landmark puncture, or etc., which are becoming obsolete. I think this is one of the fields of vascular access where the revolution will be stronger and the changes will be more radical. Yeah. Well, from the practical point of view, looking back in this 20 years, I think the most critical aspect was to assess the competence and the proficiency of the nurses and the doctors, because formation, the education of the team is the basic of it all. I mean, if you don't have a properly trained people, then the whole team, vascular access team, has no reason to exist. So it must be clear in the mind of the coordinator or the hospital management and the people who lead the team that the most important thing is that you have people who are enthusiastic, okay, which are dedicated, okay, but also which are specifically trained. And that this training has a content and has a form and a structure. The content must be the best evidence available for the safety of the patient and the cost effectiveness of the maneuver, which means that you must be trained to what is really evidence-based to be safe and cost-effective, such as ultrasound or intracavitary electrocardiography, or if we talk about maintenance, about the use of 2% correction in alcohol or the maximal barrier precaution. I mean, the glue. You must have a solid content, an updated content. And in terms of structure, the training should not be done casually, but should be done by those evidence-based recommendation of the Walkover consensus, which tells us that every time you do a training, there is also a manner for a particular pathway of education that you should follow. For instance, first theory, then practice in the lab on simulator, and then a tutored learning curve, and then a non-tutored learning curve, and then a final audit. And sometimes it's difficult to make the hospital management understand that this is the basis of all. Well, I think this implies a change of mentality. If we think that we are there for the patient, that the reason of being there in a team, of being in the hospital, is for the sake of the patient and not just for our career, and then everything becomes easier. If you have different doctors and different nurses which don't particularly like each other or have different opinions, etc., then the moment that you sit down and you make everyone understand that we are there for the patient to choose the best thing, then all this particularly non-altruistic aptitude should fall. And I think in this case, in this aspect, the role of the team leader is very important, because the team leader is the one who acts like a glue, who gives the tuning of the whole group, who makes the whole group understand that it's not a question of ambition or prevailing one or the other, or to have probably the correct pride of their own profession, but those things are secondary if we think of the benefit of the patient. Yes. Well, they should sing that old song by Ken Hit, "Let's Work Together." We start with the line, united we stand, divided we fall, because that's the whole thing about it. The more you have a different profession inside the group, the more the team it becomes solid and defendable, and also the more it's probable that we will grow culturally. And thinking about the profession, I'm not referring exclusively to doctors and nurses, but also the pharmaceuticals people, for instance, the hospital management people. They all are part of a different profession, which are whose goal is to get the best possible for the patient. So I think that l'union fait la force. We've been always, our group is always curious of everything which is happening, potentially interesting in the field of vascular access. And we have been curious, and personally I have been curious since many years ago, since I was born maybe. And more than 20 years ago, I learned this technique of intracapillary EKG from a friend anesthesiologist who used to work in Heidelberg. And after my visit to Heidelberg, I tried this technique as we were trying any kind of devices, a new technology, methodology. You try everything and then something survives, something goes on, something gets into the clinical practice. And we first used in the intracapillary EKG for port insertion in 1997 and in the following years. And after a while, we stopped making the postoperative X-ray control because we found out that it was useless. And when the PIC, the ultrasound guided PIC, came into the scene at the beginning of this century, very rapidly we have the intuition of using intracavitary EKG for PICs. And I think that we were the first group and the first hospital in the world to use intracavitary EKG for PICs at that time, because the culture of PIC, ultrasound guided PIC, was born in the Anglo-Saxon world, in USA and in UK, but in these countries they had no access to the intracavitary EKG. On the contrary, Italy was at perfect overlap between the culture of the ultrasound guided PIC coming from Anglo-Saxon country and the culture of intracavitary EKG, which was up to the moment just a thing of the German countries. So that's why we put the two things together, and very rapidly we included intracavitary EKG in our hospital policies, and at present it is strongly recommended by hospital policies that any kind of central line should be inserted by using intracavitary EKG, with the only exception of epicutaneous caval catheters in neonates, where the technique of intracavitary EKG might be difficult to achieve, and the ultrasound might be fairly easier and better. And also the exception, another exception always in neonates, which is the umbilical venous catheters, in which, as a matter of fact, the intracavitary EKG is always possible, but from the logistical point of view, it might not be rewarding, because it's a sort of a semi-emergency procedure in which you need the ultrasound anyway for the tip navigation, so it makes more sense to use just ultrasound in terms of cost effectiveness. But all of the other access, short-term, long-term, PIC ports, thoracic ports, PIC, any kind of CVC or insert in jugular, subclavian, brachiocephalic at any age is inserted by using intracavitary EKG. I think the future is to abandon radiology for the vast majority of procedure in vascular access. There is less and less need of the radiologists. As a matter of fact, that you use the radiology suite for a vascular access procedure is most of the time a waste of money, an incredible waste of money, because you achieve the same results but spending 10 times, 12 times more. And also you use a professional like a radiologist, an interventional radiologist, which is very precious for other maneuvers, which absolutely requires him. I think all of the emergency, the trauma patient, basically I am an emergency surgeon, and I tell you that if compared to 20 years ago, the number of situations in which I have to open a traumatized patient have become minimal, because everything is done by radiology, and that's the incredibly good role, great role of interventional radiologists. So there is no reason to have them wasting time, precious time, doing something which can be done exactly with the same result, the same clinical outcome, without the use of X-ray. Well, EKG, the intracavitary EKG technique was born long before the first dedicated monitor for EKG technique was born, of course. And I know about it because we started to use it in 1997, and the first attempt of doing the first dedicated monitor for intracavitary EKG occurred in my hospital something like 10 years later. So for 10 years, we did all of the intracavitary EKG without even dreaming there could be a dedicated monitor. So it's very important not to confuse the technique, the methodology of intracavitary EKG with a device which can make this technique more user-friendly. And coming to the dedicated monitor, apart from an easier documentation, a more user-friendly approach, and apart from this, it might have some special features. Example of such special features is to be able to recognize automatically the maximal increase of the P. There is always a human factor, of course, but if the human factor is also coupled with a machine which tells you mathematically which is the point of highest peak, it's better, of course. The other aspect is to be able to recognize the maximal height of the F waves in atrial fibrillation patient. Very recently has been proven by different studies that we can use the F waves of the trace of the EKG of the fibrillation, atrial fibrillation patient as a sort of surrogate of the height of the P. So a machine who will be able to recognize this height F wave will add something, will have something more than the standard monitor. Also, there are machines which may have a navigation, an EKG navigation, which also something which is very desirable. Basically, tip navigation today is performed best by ultrasound. There are some products with electromagnetic device which are absolutely not reliable and not useful, not cost effective. So the basic of the tip navigation now is ultrasound. Still, the fact of having also ultrasound is also human as a human factor because it's operator dependent. So if we can add something which is completely inexpensive and which not require additional cost, additional device as the EKG navigation performed by the same dedicated monitor, that would be another additional interesting feature. The other problem is that the future, of course, is to have simultaneously the EKG device and the ultrasound together. And the other aspect also that both should be wireless in the future. We now have a terrific wireless ultrasound that we can use, the ultrasound probe without a wire, which are connected by Wi-Fi with a smartphone or a tablet. We also have some EKG devices which are wireless and connected by Bluetooth with a tablet or with a smartphone, but we don't have the two things together. Yes. So I think the future will have a very smart, small device which simultaneously is optimal for EKG and for ultrasound and is connected by Wi-Fi or Bluetooth or whatever with a tablet or with a smartphone. That will be the thing we should work to in the future. But obviously, if a patient is already connected to a monitor, to the EKG monitor, it makes no sense to add an additional monitor, even if it's a dedicated one, which means that all patients which are in the intensive care units, including the pediatric intensive care units, including the neonatal intensive care unit, which also means all children, because we do insertion of vascular access in the pediatric intensive care unit for all children. In those cases, we use just the monitor. There are other wards, for instance, of neurology, of cardiology, where the patient is connected to the monitor. So if there is if the monitor is already there, we don't replace it. We have experience enough. We have 20 years and more of experience so that we can use any kind of monitor, even a toy EKG device, and be able to do an appropriate intercavitary EKG. For the rest of the patient, if you consider the day hospital unit where we perform every morning insertions, 7, 8, 10 insertions every morning, then of course it is convenient to have a dedicated monitor in each day hospital unit. This is what we have. Okay. If we come to the bedside insertion, things are that there are two possible options. Or to use a very small, compact device for dedicated EKG, dedicated to the intercavitary EKG technique, or to use the defibrillator, which usually is present in the ward. Personally, I prefer to use a small dedicated device, also because when you go and insert in bedside PICs, for instance, you need a cart of some kind, and on the cart you need to put your material, your insertion packs, and you have to put your ultrasound, so it makes sense also to carry in this cart also the EKG device. Well, the modified EKG system technique, the modified EKG technique is something which we invented. I mean, we were inspired by Engelhardt, but our group has worked a lot in defining this modified EKG technique. There is also another German group. There is a nice study by Steinhagen talking about this modified EKG technique. And it's the same for the standard conventional EKG technique. You should not confuse the methodology with the device. The methodology is the modified EKG technique with the scientific assumption and demonstration now with the recent studies that you can use the F waves as surrogates of the P wave. And that's something. And then you have a device, at this moment only one device, the pilot, who is able to use this methodology and put it automatically and electronically in a user-friendly way. At present, the pilot is the only dedicated EKG monitor already equipped for making the modified intracavitary EKG easier and user-friendly. So this is the story. It is also possible in the future other devices may come, may arrive in the market which will be using this methodology of the modified EKG technique can be used. At present, the pilot is unique. The pilot becomes relevant in inverse proportion to the experience of the operator. Because, of course, one of my nurses, I think of Sandro, for instance. Sandro has been working with EKG with me since 1997. So he has 22 years of EKG. The first 12 years he did with any kind of monitor. So, yes, he has the eye of the trace and the interpretation done by Sandro of a trace is incredibly swifter and rapid and accurate because of this experience. But if it is the first time that the nurse or the doctor comes to the EKG technique, of course it helps to have a device which should be particularly user-friendly. This is true for the conventional EKG technique, it's true also for the modified EKG technique. Well, I tell you that I would exclude, for instance, and I never recommend those systems which have additional tip navigation systems which are not validated or not accurate. For instance, there is one which already mentioned with an EKG technique for tip location, an electromagnetic system for tip navigation, which I never recommend because it's, I think, it's just a commercial trick for raising the price. Another which I will never recommend, but now it's disappearing, I think, is from another company. It's an EKG technique with a Doppler tip navigation system, which also has no validation at all, and is rapidly disappearing. So if we look only at the intracavitary EKG devices, I think that I don't like the idea of making a sort of hit parade or what is best, but I can tell you the top 5. I can tell you the criteria. The criteria should be, first, the smaller, the better. So if you have a tablet rather than a laptop, of course the tablet is much better. Also because you need this kind of device specifically when you go bedside inserting catheters. Second, how user-friendly is in terms of knobology. You know knobology? Meaning if you have too many knobs, too many cursors, too many, that will be discouraging the operator. So the ideal device should have a very few and very simple to use. This must be intuitive, exactly. The other aspect, it should be user-friendly in the interpretation. You should facilitate interpretation. So if you have a double screen with something that you can freeze and then something that you can compare with, that would be of course better than if you have just one trace going on, etc. One other aspect which regards infection prevention is that everything should be keyboardless. So you should have something which is a complete touch screen. Every time you have a keyboard, you have a risk of bacterial contamination. So the tablet is the name of the game. The other aspect is that you should have something with some additional features, such as the possibility of doing something that you will never do with a standard monitor, which might be printing, for instance, or to take a snapshot which can be forwarded by USB key or by Bluetooth to another computer, etc. Or to be able to do some software special routine, such as, for instance, the recognition, automatic recognition, the F-wave, or the automatic EKG navigation, which are two software specialty. Something which will make the difference if compared the use of a standard monitor. Last but not least, I think that to have a wireless connection between the device itself, the device which connected to the electrodes, and the tablet should be something very desirable. The story is different in USA and in the rest of the world. The rest of the world, I mean Europe and Australia, basically, but also Latin America, but especially Europe and Australia, the midline are in a great moment of success, especially the short midlines. Also because we are simultaneously using, both in Australia and in Europe, the old traditional, conventional midline, which are more than 20 centimeters, 20-25 centimeters, and the new short midlines, who are really two different devices which deserve differentiation because they have different indication, they have different duration, different technique of insertion, different complications. And the midline, the old-fashioned midline or mid-clavicular are still going strong, especially in Spain, in UK, and Italy, with always the concern of being used properly only for peripherally compatible solutions. But the real focus now is on short midlines, which are probably the most rapidly rising device on the market, venous access device on the market. And I see, for instance, my hospital where from 0 to 1,000, 2,000, 3,000 per year. This is the entity, the magnitude of the rise for the short midlines. Short midlines, they erode, so to speak, the field of the short cannulas. They are a terrific replacement of having the patient restarting many short cannulas during its hospitalization. So they have their role basically in the emergency room and in the hospitalized patient. On the contrary, the standard old conventional midline, mid-clavicular, they will keep their role in palliative care basically, and in some kinds of OPAT, outpatient antimicrobial therapy, if the antibiotic is compatible with the peripheral route. And in USA is different. In USA they abandoned the midline and they have rediscovered the midline as a short midlines, but they call it midline with no short midline, so that if you look at the literature there's always great confusion, because depending on where the paper comes from, when they say midline it might be indicating completely different vascular access devices. Now there is a very nice paper from Australia which deals with this classification. There is a new classification by Wokova, by Gaveset, which will be adopted, I think, also in Europe, because we are working on these guidelines for the classification and for the use of peripheral access device, where this differentiation between short cannulas, long cannulas, and standard midlines will be clear. Well, we've been using midlines since the beginning of this century, and together with PICs, and we were using traditional midlines, ultrasound guided, with also in hospitalized patients. And then very rapidly we stopped because the cost effectiveness in the hospitalized patient was reduced. On the contrary, we are still using it in on non-hospitalized patients who need the peripherally compatible solutions for months. Okay. When we got the short peripheral cannulas, the long peripheral cannulas, the mini midlines, we reconsidered this indication, and we started to use the long peripheral cannulas, or short midlines, how we call it, for the hospital use, for the same kind of use of the midlines of 15 years ago, but we increased the cost effectiveness. It's two problems. First, the cost, because we currently use shorter midlines who cost maybe 1/4 or 1/5 of the traditional midlines. And also it was a problem of confusing the device, because the way that the standard midlines were designed was very, very similar to PIC. So in spite of the fact that you should read the name of the wing, or you should have a label, etc., there was always the risk of confusing a traditional midline with a PIC. So these were the two factors. As a matter of fact, we had a lot of catheter-related thrombosis due to midline, exclusively because of improper use of the midline. And improper use was not only a question of ignorance of the hospital policies, but also a question of confusing something which, when you look, looks very similar to the PIC. Now, the difference is a question of length, a question of the overall position of the device. The mini midline has a length typically 8 to 10 centimeters, and the whole device is contained in a vein of the arm, of the forearm. On the contrary, the standard midline is something which is typically 20-25 centimeters. It starts in a deep vein of the arm, not at the forearm, and the tip is in a thoracic area. So the midline starts at the arm and gets in the thoracic area, either in the axillary tract, in the axillary vein in the thoracic tract, the subclavicular tract, or in the subclavian vein. The risk of thrombosis is not related to the length of the catheter, but it's related to the kind of infusion that you do through it, whether it's peripherally inserted or not. So if you have a PIC which has become shorter, whose tip is subclavian, brachiocephalic, you can still use it for clear fluids, peripherally compatible, thrombosis will not occur. Sometimes it may happen that in spite of the effect of using peripherally compatible solution, the tip is in a cumbersome position. For instance, it is blocked against the wall of the vein. For instance, if you have a PIC coming from the left, who have not properly entered the supravena cava, and the tip is stuck into the lateral wall of the supravena cava, even if you use it with peripherally compatible solution, still there will be a trauma to endothelium, which will give you thrombosis because of a mechanical trauma. You know, the endothelium responds to any kind of injury with the same way, by forming a thrombus, which is a repair tissue for the endothelium. Which means that if you have a mechanical trauma, a chemical trauma, or infective trauma, the endothelium will always do the same thing. When it's ruptured, it will start a thrombus. Well, yes, there's another issue which is related to thrombosis, the fact that if you reduce critically the residual blood flow, you will get a thrombosis. But this is not the problem where the tip is the problem of that part of the vein which is smaller if compared to the caliber, which is basically is the reason why you get thrombosis at the site of insertion. And in this regard, of course, there is confusion, as you said, between the peak of the 20th century and the peak of the 21st century. The peak of the 20th century was inserted without ultrasound in veins whose caliber was unknown. On the contrary, the peak of the 21st century are inserted by ultrasound in vein of caliber which is known, and the trajectory is known, and the possible anomalies are known, all thanks to ultrasound. And there are some meta-analyses which are badly conceived who give wrong results. The most famous is the meta-analysis, so-called meta-analysis by my friend Vinay Chopra on the Lancet, in which there was a confusion between peak of the 20th century without ultrasound, the peak of 21st century with ultrasound. And it was only one of the fault of that meta-analysis, but unfortunately it was quite successful. So there is still a bad press, come si dice, una leyenda negra, por el peak, about the peak. So people, the less competent they are, the more believe that the peak are associated with thrombosis, which is absolutely not true. We recently published a paper, the first name is Balsorano, which was done by a Gavset group based in Florence, in which we revised completely the meta-analysis performed by Chopra, and we came to opposite conclusion. The thrombosis is something which is related for peaks to the technique of insertion. That's all. If you minimize the trauma, if you take care of the proper ratio between the caliber of the vein and the caliber of the catheter, if you use ultrasound or intracavitary EKG for the tip location, and you have a proper intraprocedural tip location, and last but not least, if you stabilize properly the peak, which means to use a sutureless device, transparent membranes, glue, then the risk of thrombosis will be very, very, very low. And there is no convincing evidence today that the risk of thrombosis related to a peak is better or worse than the risk of thrombosis to a CICC. On the contrary, there is wide evidence that the femoral inserted central catheter has a higher risk of thrombosis than both the PIC and the CICC. Which means that, for instance, to use a femoral line because you're afraid of a PIC thrombosis is completely stupid. Well, the future of traditional, as much as the future of traditional midline is in the extra-hospital setting, the future of short midlines is the intra-hospital setting. And they have a clear-cut indication whenever there is a DIVA, a patient with difficulty in venous access, or when there is a patient with no difficult access, with easy access, but with a peripheral line which is meant to be inside for more than 1 week. These are the two big indications of mini midline. As with any other kind of device, it must be inserted by specifically trained personnel. So if someone tells me that they have a bad experience with mini midline or PIC port or whatever, but they leave the insertion to non-specifically trained personnel, I don't care. There's nothing I can do about it. There is no such thing as a technology which has learning inbuilt, so to speak. You always have to make a little effort to use and to adopt new technology, a new methodology, a new device, etc. Of course, the good technology makes things easier, but still there must be some training. Well, it's easy to be said. First, we have realized that there is no indication whatsoever for silicone picks. There is really no evidence. I mean, to use silicone picks today is absurd. You should use not only polyurethane picks, but power injected polyurethane. There is no reason for not using power injected polyurethanes. As a matter of fact, the power injector is something which has increased the performance, which allows the pick to be used for hemodynamic monitoring, which reduces the risk of reversible obstruction, because all obstruction are reversible if you use power injectable picks. In our hospital, we stopped using urokinase and other thrombolytic drugs, only because we now can resolve practically any obstruction with hydraulic pressure. Because just the fact that when you have a power injectable pick, you have something which is resistant to 300 psi and something, which means that you can use for unblocking the catheter even a 2 ml syringe, which makes a 200 psi, which will be forbidden if you don't use a power injectable. If you use the silicone picks, then you should only try to unblock with a 10 ml syringe. But a 10 ml syringe does a pressure of 50 psi. And the 2 ml syringe does a pressure which is 4 times higher, which means that you have 4 times more chance to unblock a power injectable catheter, because you can use the 2 ml syringe than you have with a standard catheter, non-power injectment, which uses the 10 ml syringe. Absolutely. It makes it a blood sampling, it makes it a hemodynamic monitoring. It is less prone to tip migration. It is less prone to dislocation. Also, when you change the dressing, it has so many advantages, and practically the cost is the same. Yes. And the other thing which has completely changed, if compared to 20 years, is that now we know that there is no role whatsoever of valved picks. The proximal valve, distal valve, during the last 3 decades have shown to have absolutely no advantage over the non-valve catheter. The valve catheter is only a commercial trick for selling something which is more expensive, but it has no additional advantage. As a matter of fact, many valved catheters, on the contrary, they have a higher risk of malfunction, they have a less flow by gravity or things like that. Then there are some special features which might be interesting. For instance, one feature is to have a power injectable pick with the proximal trimming, which is also something which makes the EKG maneuver easier, makes the tunneling easier, but still there are some limitations because this technology can be applied only to 1 lumen picks. And then there is the interest of having picks treated with medications for anti-infective, anti-thrombotic purposes. Impregnating, yes. And impregnating or coated, which are 2 different techniques. Unfortunately, there is no evidence at this moment that there is for any kind of a real effect of impregnation with silver, for instance. There is no evidence of the effect, the anti-infective effect of picks coated with chlorhexidine. And there is little evidence, though there is something about the coating of picks with antibiotics. Still, the cost effectiveness is not clear yet. Yes. And on the other aspect, antithrombotic, there is no evidence-based data yet. There are some data suggesting a possible antithrombotic effect with an impregnation by a special ceramic called Indexo, but still is not something which can be considered to be effective. And even if it's effective, we should discuss whether it is cost-effective or not. So for the moment, the treated pigs are in a limbo from which we don't know exactly who will come out or who will stay. Yes, well, I would say that at the moment the problem is that it's clear that the success of pig insertion in terms of puncture is related to the quality of the needle, the quality of the guide wire, the quality of the microintroducer. And success of pig insertion in terms of progression and proper position of the catheter is linked, associated with the quality of the catheter. So, which means that it's not the catheter only which makes the difference. And in this regard, the Europeans are quite smarter than USA, because in USA they think that any accessory will be okay, any guide wire will be okay, any needle will be okay. On the contrary, we know perfectly well that we must have the best needle possible, the best microintroducer possible, the best guide wire possible, and best catheter possible, all together in the same pack. And this does not happen. There is no kit which I know of which is absolutely the best in any kind of accessory. So instead of trying to have something new, which maybe we don't need it at this point, when we do our tender in my hospital, we try to evaluate the quality of each accessory, because they are often underestimated in their value by the company, and try to have the best possible kit by weighing the quality of each of this specimen. Well, the packs is something which have changed our life positively. It's terrific. I mean, PACS is something which is required by the guidelines, which is cost effective because, of course, the cost of the whole pack is lower than the sum of the cost of the single specimen which are inside the pack. I think I consider a pack as one of the great new things which happened in the field of vascular access. I've been inserting central lines for more than 40 years now, because I started in 1977. And I tell you that for the first 20 years of my life, to have the hard thing before inserting a central line was to get together all the material which was needed, which was in the components. It was an incredible waste of time. And now we have less waste of time and less possibility of manipulation, less risk of infection, less risk of mechanical complications. So the pack are something which are needed. In my hospital, we have now a pack for the insertion of central venous catheters, and another pack for the insertion of ports, PICC ports and chest ports. And I think we can manage. In the future, I think we also have pack for the insertion of mini-mid lines, which makes sense. We have been using heparin in the last century, in the 20th century, on the supposition or suspicion of efficacy, but there was never the evidence, the scientific evidence. In the last 10 years, many groups, especially from Europe, from Belgium, from Italy, etc., they have reconsidered, from France, they have reconsidered the real efficacy of heparin in keeping the catheters patent, and they find that there was no such evidence. And there were many papers, many studies in recent years showing that locking with saline or locking with the heparin has exactly the same effect. And considering that heparin is more risky and more expensive than saline, which means that you should not use heparin anymore. With the only exception of catheters which must have an anticoagulant always, which is dialysis catheters and apheresis catheters. But still, it's not automatic that the anticoagulant means heparin. As a matter of fact, heparin may also increase the formation of biofilm by Staphylococcus. Heparin might be associated with allergy or toxic effect, like HIT. On the contrary, citrate is a completely natural organic substance, and no one will ever be allergic to citrate, for instance. Also, citrate is the main way we get an anticoagulation in the circuits of the dialysis machine and the apheretic machine. So it makes no sense to use an anticoagulant for the blood while it's running the circuits, but use another kind of anticoagulant for the catheters. Obviously, it must be stressed that the 4% citrate we're using is a powerful anticoagulant, as powerful as heparin, but is very mild as anti-infective. To get an anti-infective action or anti-biofilm action, you must go to 10, 14%, even 45%. And at this concentration, the safety of citrate is reduced. So I think the lesson here is that for the moment you should use the citrate more for the anticoagulant effect and anti-infective effect. It's better than heparin, but in order to get a serious anti-infective effect, you must go to 14% or 45%, or over 10%, over 10%. If you're really looking for just an anti-infective effect, and this is for all catheters, not only for dialysis catheters, but for instance also for pores, for PICCs, and then in the future we'll probably be using a taurolidine lock. But taurolidine has no anticoagulant effect, just a very powerful anti-infective, anti-biofilm effect. Usually it's 1.3% or 2%, but it's a different story. So the future of the lock for PICCs and pores is not for the purpose of preventing occlusion, but for the purpose of preventing infection, or also for decontamination of colonized catheters, which is also a very attractive possible role for taurolidine. Muchas gracias. Mi español no es suficiente para exprimir